Sekali serem. Belum. Belum. Dr. Preeti, we can start.
All right. We
Yeah.
can we wait
Uh,
for a minute if we're expecting more people to join in.
okay. Okay. Then we'll wait for 2 to 3 minutes more.
All right. Hello.
Yes, doctor.
Yeah. So Priya, so one doubt I had is, are we expecting any simultaneous translation to be happening as I go ahead with the slides, or how is
Uh,
it going?
yes, ma'am. As you speak, you'll have to pause occasionally so that, translator can convey your message accurately.
Okay. And who would
Yes.
be doing the translation?
Ma'am, we have Yaovi with us. He's the translator. Yaovi, can you hear us?
Yes, I can hear you. Hi,
Yeah.
everybody.
Yes.
Hi. So, so I would like to go slide by slide. So
Okay.
I can probably in areas where it's going to be more detailed description, I can pause in between. Otherwise, if it's just a short description per slide, I'd like to complete that and then I'll wait for you to complete the translation. Is that okay?
Yeah, it's okay.
Okay. Dr. Preeti, shall we start?
Yes, yes.
So before we start with the presentation, I'll introduce you to our participants. So good evening, everyone. Welcome to today's webinar. We are delighted to have all of you here for this session. It is my pleasure to introduce our distinguished speaker, Dr. Preeti Vijayakumaran. Dr. Preeti is a highly accomplished surgical oncologist at Artemis Hospital, Gurgaon, with over a decade of experience. She has trained at premier institutions including Tata Memorial Hospital, Mumbai, with a specialization in thoracic oncosurgery. She is known for her compassionate care and commitment to clinical excellence. Dr. Preeti, we truly appreciate you taking the time to share your expertise with us today. Uh, I've also introduced the translator, Yauvi, who will be helping our doctors from DRC follow along smoothly. So without further ado, let's begin. Dr. Preeti, over to you.
Thank you so much, Supriya. A very good evening and good afternoon to everybody who is attending this small and short but yet fruitful webinar on esophageal cancer. When I was told that we should be discussing a topic on cancer, I was, as a thoracic surgeon and as a cancer surgeon who has special interest in thoracic surgery, I immediately thought about esophageal cancer because this is a malignancy which is a big burden and a major challenge in all of our countries, especially in the South East Asia and African continent. As we see very high incidence over here, and so is a difficult uh, time when we face these patients, especially the ones who present with locally advanced disease. This is an ever-evolving field. Even recently, there's a lot of active research that is going on in esophageal cancer management. And I'm sure I will not be able to cover the entire topic, but I'll try to do justice to the 1 hour that we have ahead. And I am looking forward to good participation from your end. Please feel free to ask me any doubts towards the end of the presentation. And I hope we have a good session.
Bonjour et bienvenue à tous pour cette petite présentation sur le cancer de l'ésophage. Quand on m'a parlé du sujet du cancer pour euh, discuter dans cette présentation, j'ai tout de suite pensé au cancer de l'œsophage, qui est un fléau qui touche beaucoup de nos pays, que ce soit en Asie ou en Afrique. Donc, cette présentation servira à donner un peu plus d'informations, un peu plus d'outils pour une meilleure gestion et un meilleur diagnostic de ce cancer.
Okay, so going ahead with the presentation. So like Supriya has already introduced, very briefly to tell about myself, I'm Dr. Preeti Vijayakumaran. I'm a surgical oncologist trained at Tata Memorial Hospital, which is the highest volume center in our country. And here, during my tenure, I had the opportunity to work in the thoracic unit and have done a fellowship in thoracic surgery with great deal of exposure in thoracic malignancies, esophageal cancer being one of the most common among the cases that we dealt with on an everyday basis.
Je suis docteur Preeti Vijayakumaran, donc j'ai fait mes études et mon stage dans le domaine du cancer de l'œsophage et c'est l'un des cancers les plus récurrents, donc c'est un plaisir d'en parler ce soir.
So going ahead with the statistics of esophageal cancer, the Globocan ranks esophageal cancer as the 11th most common cancer in terms of incidence and the 7th most common cancer in terms of the mortality that we face due to such malignancies. As we can see, lung cancer ranks the highest and its esophagus is not very far behind.
Le cancer de l'œsophage sur le plan mondial est classé 11e en termes d'incidence, mais classé à la 7e place en termes de mortalité.
When we talk about continent-wise distribution, Asia faces the highest number of these cancers, whether it be the incidence, the prevalence, or the mortality that we see with esophageal cancer, closely followed by Europe, Africa, North America, and the other places.
L'Asie est en tête du niveau d'incidence de la mortalité et de la prévalence en ce qui concerne le cancer de l'œsophage, suivi de près par l'Europe, et l'Afrique se retrouve en 3e position.
This graphical representation gives us a much clearer description of how high the incidence of esophageal cancer is, and it's the highest in Eastern Asia, followed closely by Eastern Africa, Southern Africa, and other Southeast Asian countries.
Ce graphique nous montre l'incidence du cancer de l'œsophage et son taux de mortalité. Et on peut voir que l'Asie de l'Est est en tête en termes de mortalité, suivi de l'Afrique de l'Est, ensuite de l'Afrique australe.
When we discuss the 8 standardized incidence, the male proportion of this esophageal cancer is significantly higher when compared to the female incidence.
Le taux de mortalité ou le taux de prévalence est plus élevé au niveau des hommes que pour les femmes.
How do these patients present? Now, in our country, the biggest challenge that we face is most of these patients have very subtle signs to begin with, but they keep ignoring these symptoms until they are full-fledged blown malignancy, probably in stage 2, stage 3, or even in many cases, stage 4, by the time they present to us.
Beaucoup de patients ne font pas un diagnostic assez tôt, ce qui fait que quand ils font le diagnostic, ils sont déjà au stade 2 ou au stage 3 ou un stage assez avancé, ce qui complique encore plus le traitement.
So the real challenge is to pick up these cases early. And how do we pick them up early? So the symptoms in an early stage malignancy are very subtle. Most of these patients don't have any symptoms, or they may have slight discomfort while swallowing, and they classically complain of slight difficulty, and which is progressive increase in such difficulty mainly for solid food and lesser for liquid food. But having said that, most of the cases of real early stage esophageal cancer are detected by screening. So, in countries where they have a more stringent screening endoscopic protocol, they do pick up early dysplastic changes and early malignancy.
Le problème dans l'identification de ce cancer, c'est que ce n'est pas facile à identifier au stage du début parce que certains patients présentent uniquement des signes de difficulté pour avaler, ce qui n'est pas forcément facile à identifier dès le début. Mais dans certains pays où les techniques de scanner sont avancées, cette pratique peut permettre d'identifier ce cancer de l'œsophage dans les stages du début.
So, how do they present if they have become more advanced? They have more classical symptoms. A, they have difficulty in swallowing, dysphagia, may not be associated with pain. Second, they have unintentional weight loss, which is progressive. Significant weight loss is concerned if the patient has lost about 10% of the body weight in less than 3 months duration. Some of them have heartburn like symptoms, regurgitation, food getting stuck down the throat like symptoms. More aggressive tumors or more obstructive lesions can present with vomiting and sometimes with blood vomiting, hematemesis. When the tumor becomes more advanced and advances into nearby structures, they could also present with coughing and hoarseness of voice.
Les premiers signes sont généralement la difficulté pour avaler ou une perte non intentionnelle de poids, mais quand le mal avance à un stage avancé, on peut avoir des signes comme le vomissement, des indigestions et aussi de l'enrouement.
Okay. So, how do we evaluate these patients? Besides the basic blood investigations, which are done for all of these patients routinely, including the complete hemogram, the liver function test, and the renal function test, the essential evaluation technique to clinch the diagnosis is an endoscopy and an endoscopic biopsy.
Comment nous procédons pour l'évaluation? Mis à part le diagnostic par les tests de sang, nous avons aussi des techniques avancées comme l'endoscopie qui nous permettent de faire un diagnostic beaucoup plus avancé.
So, I would like to divide the evaluation into two groups. One are diagnostic investigations to confirm the malignancy. The second is staging investigations.
J'aimerais diviser l'évaluation en deux catégories, le diagnostic, ensuite voir l'état d'avancement.
So, in diagnostic evaluation, any patient presenting with difficulty in swallowing, which is progressive in nature, should undergo an endoscopic evaluation, the purpose of which is two. First, to identify what is the intraluminal problem which is causing the difficulty in swallowing. Second, to identify what is the extent of this problem. That is, when compared to cricopharynx up to the GE junction, what is the exact extent from where the lesion or the problem is beginning to where it ends. And then this procedure is coupled with a biopsy.
En ce qui concerne le diagnostic, la première étape consiste à évaluer l'état d'avancement ou bien ce qui cause exactement la difficulté pour les personnes d'avaler de la nourriture.
Okay. So as we can see in the table which is given over here and in the staging recommendations that I have mentioned, these are the standard staging investigation that we use in a case of esophageal cancer, but there is a variation according to the presentation. So one of the essential things is to do a CECT thorax and abdomen, or now more fondly, we do a PET CECT whole body. Now, when we do a PET CECT, it has the added advantage of incorporating the CT along with the FDG study, which gives us a more accurate staging for esophageal cancer.
L'une des techniques les plus avancées que nous utilisons, c'est la tomodensitométrie photométrie avec injection de produits de contraste qui permet d'avoir des résultats beaucoup plus clairs.
So in a PET scan, what are the things that we see? Is first we see what is the local extent of the tumor in terms of whether it's involving the upper esophagus, middle esophagus, or lower esophagus. What is the circumferential extent of the tumor? How many adjacent structures are closely abutted or involved or even invaded by the tumor? Next, we see the extent of lymph nodal disease in the thoracic part and also in the cervical region and in the intra-abdominal region. And third, we also look for sites of metastasis, which is like lung metastasis, liver metastasis, peritoneal disease, or nodal areas which are beyond the regional nodes.
Une autre manière de faire le diagnostic, c'est en utilisant la technique du PET, qui est un examen qui utilise un traceur radioactif et qui permet de détecter les cellules cancéreuses très actives.
After doing the PET scan, now if it's an early disease, I would like to get an endoscopic ultrasound done. Why? Because an endoscopic ultrasound provides a more accurate staging in terms of what is the T stage and what is the end stage in an early esophageal cancer. But in cases where the tumor is stricturous and it's tight, an endoscopic ultrasound may not be possible, where we rely on the axial imaging of CT or PET scan to determine the T stage and end stage of disease.
En faisant le diagnostic, l'objectif, c'est d'identifier l'état actuel et le potentiel état d'avancement. Ensuite, nous utilisons les techniques du PET et de CET pour évaluer ce qui suivra.
Where do we do other investigations like bronchoscopy and laparoscopy? Bronchoscopy is done in patients who present with a locally advanced kind of disease on imaging, which may be closely abutting the carina or the left main bronchus, and we suspect an airway invasion, or the patient may have hoarseness of voice or excessive coughing, where we may suspect a tracheoesophageal fistula. Also, bronchoscopy guided EBUS technique can be useful for assessing the T and N stage in patients with a stricturous tumor.
La bronchoscopie est l'emplacement exact des tumeurs et la démarche à suivre pour les traiter.
Laparoscopic technique is essentially needed in cases of adenocarcinoma involving the G junction, which is the gastroesophageal junction, extending into the proximal stomach to rule out any omental or peritoneal metastasis, which is usually done in locally advanced adenocarcinoma of Sieverts 2 or Sieverts 3 type.
La laparoscopie est plus utilisée dans des cas beaucoup plus avancés.
So now, the essential take-home from here is for an early stage, besides the PET scan and US can be significantly contributory, but for a locally advanced stage, a PET gives us good information, which can be supplemented with bronchoscopy and laparoscopy in cases where it is recommended.
En résumé, pour un diagnostic en état de début, le scan, la technique du scan par PET ou le EUS sont les plus recommandés, mais on peut aussi ajouter la bronchoscopie au besoin.
Now, how do we stage esophageal cancer? This is as per the AGCC staging of TNM. And as we see, understanding this is extremely important for us to decide on our further line of management. Esophagus is divided into thoracic esophagus and cervical esophagus. Cervical esophagus extends from 15 to 20 centimeters of esophagus from the incisors. From 20 to 40 centimeters is the thoracic esophagus, which is further divided into upper, middle, and lower. Supriya, there is some commotion.
Yes, I'm trying to mute him. Yeah.
Yes, Yogi.
Ok, le cancer œsophageal est divisé en différentes parties en fonction du niveau d'avancement. Donc, entre 15 et 20 centimètres, on a l'œsophage cervical. Ensuite, entre 20 et 25, le thorax supérieur et le thorax moyen va de 25 centimètres à 30 centimètres. Et au-delà de 30 centimètres jusqu'à 40 centimètres, on a le thorax inférieur.
When it comes to the T staging, T1 is diseases which is limited to the mucosal areas involving the basement membrane, lamina propria, and the muscularis mucosa. Disease extending beyond the muscularis into the submucosa becomes T2. Disease extending into the muscular tissue becomes T3, and which reaches the adventitia as T3. Disease which goes beyond the adventitia to involve adjacent organs becomes T4A and 4B. If the disease is resectable, it means it's involving the pleura, pericardium, or diaphragm. It's T4A. Once it involves vital organs like the trachea and aorta, which is unresectable, it is T4B.
Donc, l'état d'avancement dépend aussi de l'état d'infiltration du cancer dans les cellules. Et on peut voir ici les différentes étapes allant de TA1 à TA4 en fonction du niveau d'infiltration du cancer dans les cellules.
As far as the regional nodal involvement is concerned, if there are 1 to 2 nodes involved, it's N1. 3 to 6 nodes involvement is N2. More than 7 nodes or equal to 7 nodes involvement makes it N3. Once the disease goes beyond the beyond the regional nodes to involve other organs like the liver, lung, and high neck nodes or para-aortic retroperitoneal nodes, it is considered metastatic disease.
Nous avons les différentes étapes qui sont regroupées en différentes phases. On a la phase N1 qui implique que une ou deux organes seulement ont été touchés. La phase N2, c'est au cas où 3 à 6 organes ont été touchés. Et au-delà de 7 organes, on parle de la phase N3.
Now, why is staging important? Staging is important for deciding the plan for management, but staging is also very important to prognosticate the patient and to have an idea of how the behavior of this disease is likely to be. In these two charts that we see squamous cell carcinoma and adenocarcinoma of esophagus, and we see that as the stage progresses, the risk adjusted survival for the disease keeps getting worse. Survival keeps getting slimmer and lesser. And as we can see in stage 2 disease, we see that the approximate 5-year survival is somewhere around 30 to 40% for both the adenocarcinoma and the squamous cell carcinoma, with the adenocarcinoma group doing slightly better here.
Nous pouvons voir sur ces graphiques qu'au fur et à mesure que le mal se répand, les chances de survie se réduisent. Et on peut voir qu'au niveau de l'étape 2, les chances de survie sont de 30 à 40% avec un peu plus de chances pour ceux qui ont le carcinome.
So how do we classify and how do we treat them? There are several parameters which are very important in deciding how do we go ahead with the management. The most important among this is the stage of the disease, whether it's an early, intermediate, or advanced stage. The next important thing is the histology of the disease, whether it's an adenocarcinoma or squamous cell carcinoma. The third, but the most important that I consider, is the patient status. How fit is the patient to undergo any type of management? The difficult challenge of esophageal cancer is that this is a disease of older population. People presenting are usually 50 above, 60 above, sometimes even 70 above, who are not in the best of their health, have multiple comorbidities. Hence, this per se becomes the biggest challenge in deciding the suitability of treatment according to the patient's condition.
Il y a plusieurs éléments pour classifier les différents patients. Le premier est basé sur l'étape, à quelle étape de la maladie, le diagnostic a été fait. Ensuite, nous avons de quel type de cell il s'agit. Est-ce que c'est le carcinome ou c'est le adénocarcinome? Et le troisième facteur, c'est l'état de santé du patient. Et si nous avons des patients qui sont peut-être dans un âge avancé et qui ont un état de santé euh, un peu, un peu en deçà de la norme, ça complique encore plus le traitement.
Now, among the stage, the early stage disease is clinically T1A, T1B, N0. And intermediate stage disease is clinical T2, N0. Anything more than this goes into the advanced stage of disease or locally advanced CA esophagus.
Donc, les différentes étapes sont au niveau de l'étape du début, on a le T1A, le T1B, et l'étape intermédiaire, c'est le T2, et l'étape avancée, c'est le T2 à T4.
Again, what we were discussing earlier. Once the esophageal cancer is diagnosed and staged according to CT, PET, or EUS, we decide whether the disease is feasible for an endoscopic management or requires a surgery or requires multimodality treatment. If the disease is very early stage, then an endoscopic treatment can be offered. If the disease is intermediate or advanced stage, then a multimodality treatment is individualized according to the patient's condition.
Nous décidons du type de traitement à donner en fonction de l'état d'avancement. Si on est à un état du début, l'endoscopie peut être suffisant. Si on est à un état assez avancé, on peut recourir à la, à l'opération ou alors à un ensemble de traitements qui inclut à la fois l'endoscopie et l'opération.
Now, what are the options that we have for esophageal cancer management? For an early stage, we have local therapy, which is either an ablation therapy or an endoscopic resection, EMR or ESD. We have the option of surgical esophagectomy. We have the option of offering systemic therapy, which could be chemotherapy, immunotherapy, targeted therapy, radiation, EBRT or brachytherapy, and of course, the nutritional rehabilitation and physiotherapy for chest rehabilitation are essential components of esophageal cancer management.
Nous avons plusieurs types de traitements. Ça peut être la thérapie locale, ça peut être la chirurgie, ça peut être une thérapie systématique, la chimiothérapie, l'immunothérapie ou une thérapie ciblée, ou aussi on peut recourir à la radiothérapie ou un support nutritionnel ou à la physiothérapie.
This is a brief description which gives us a comprehensive idea. And I would like to go into detail according to the individual stage where we will discuss more about it. But to put in a nutshell, if it's an early disease that we are dealing with, which is clinically T1A, N0, M0 disease, then I'm going to think about an endoscopic ablation versus a resection. If it is going to be a locally advanced disease, then for a squamous cell carcinoma, the preference is going to be a neoadjuvant chemoradiation for a person who will come up for surgery, and for an unresectable disease, a definitive chemoradiation. For an adenocarcinoma, it's going to be a neoadjuvant chemotherapy, that is a perioperative protocol for chemotherapy. And in some cases, a neoadjuvant chemoradiation followed by surgery can also be used.
Pour l'étape du début, l'étape T1, l'endoscopie peut être suffisant, mais si on avance un peu dans le diagnostic et qu'il s'agit plutôt de l'adénocarcinome, donc on peut avoir recourir à la chirurgie dans ce cas.
Patient preference and patient fitness are utmost importance when thinking about these options and guiding further management.
La préférence des patients est très importante en ce qui concerne les conseils et la décision à prendre.
Now we're dealing with the early esophageal cancer. So what is early esophageal cancer? Just to remind ourselves, it's clinically T1N0. So clinically T1N0 can be a can be a TA, T1A or a T1B. What is T1A? It is disease that is extending up to the muscularis mucosae, as we can see over here. And what is T1B is disease that is reaching up to the submucosa, but has not reached into the muscularis propria. And these are node negative diseases.
L'étape du début dont nous parlons, pour un rappel, ce sont les étapes qui sont à l'étape T1 et T0 et qui incluent les maladies qui n'atteignent pas encore l'épithélum.
Early stage esophageal cancer management mainly depends upon several factors, but the most important among this is to understand what is the size of the lesion and what is the histology. It could be an adeno or a squamous cell carcinoma, but if it's a poorly differentiated disease, they are not feasible candidates for endoscopic management or ablation. Secondly, if these lesions are T2, then clearly they're ruled out. Thirdly, if there's a node positive disease, then we should not be considering any endoscopic treatment.
Nous avons pour les étapes du début, on peut considérer la taille de la lésion pour savoir si on est à un stage de début ou pas. Et il faut aussi considérer que ce sont des indications qui ne nécessitent pas forcément une chirurgie.
So if we have an intramucosal lesion, which is either a carcinoma in situ or disease extending only up to the lamina propria, and it's well and moderately differentiated cancer, then we can offer this treatment as we can see on the left side of the screen. If it is a flat lesion, which is a high-grade dysplasia or a intramucosal carcinoma T1A limited to the lamina propria, then we can try for an ablation or an endoscopic resection. But if the tumor is nodular, then EMR is essential. Ablation alone is not sufficient. If the disease is T1A extending to the muscularis propria, irrespective of the distance of extension, EMR or ESD is advisable. If the lesion is less than 2 centimeter, then EMR is preferred. If the lesion is more than 2 centimeters, ESD is preferred.
Si la plaie est moins de 2 cm, on peut avoir recourir à l'IMA, mais si elle est plus que de ça, donc on peut recourir à la chirurgie.
If it is an endoscopic squamous cell carcinoma, if it's a T1A involving the muscularis mucosa, but if it's an early muscularis mucosal invasion, M1, M2, then if it's less than 15 millimeter, then an EMR, more than 15 millimeter, and ESD is preferred. But if the same disease is extending to the inner lining of the muscularis propria, then they are at higher risk of nodal recurrence. Hence, we usually don't prefer an endoscopic management.
À un stade du début, nous préférons plutôt le scanner et nous allons utiliser des techniques beaucoup plus avancées si c'est un stage beaucoup plus avancé.
If the disease is more than 2 centimeter involving the submucosa, and if it's an esophageal adenocarcinoma with T1B SM1 involvement less than 500 microns, then we can offer them endoscopy, but they are at high risk of lymph node metastasis. And if it's esophageal squamous cell carcinoma with less than 200 microns of submucosal involvement, we can also offer them an endoscopy, but at high risk of lymph node metastasis. To say conclusively, in our practice, in our hospital, for a T1A less than 2 centimeter, well moderately differentiated, we go ahead and offer them an endoscopic treatment if they understand the need for surveillance. For all other cases, we prefer to advocate surgery unless the patient is not fit to undergo an esophagectomy.
De façon résumée, pour les cas qui sont dans la catégorie TA1, nous suggérons une endoscopie. Et pour tout autre cas différent de TA1, nous suggérons la chirurgie.
So again, to understand, if it's more than 1.5 centimeter lesion, then we have to prefer either an ESD or a ESD versus esophagectomy decision should be made, especially for a T1B disease. But if it's less than 1.5 centimeter, then an EMR can be done, followed by a multidisciplinary group discussion on need for further treatment.
Si l'ablation est plus de 1,5 cm, donc nous suggérons l'IMR, mais si c'est moins de 1,5 cm, l'IMR n'est pas recommandé.
How do we manage a locally advanced esophageal cancer? So here the treatment is always multimodality. It is either neoadjuvant chemoradiation or chemotherapy followed by surgery with further adjuvant treatment in recommended cases, or it is surgery followed by some adjuvant therapy depending on whether the disease is T2 or T3, T4 at presentation.
L'état d'avancement est aussi déterminé par plusieurs facteurs et en fonction de ces facteurs, nous pouvons suggérer un traitement unique ou plusieurs traitements qui rassemblent des petits traitements qui seront utilisés ensemble pour arriver à une solution.
If you have a cancer center where you work at, ideally the management should always be a multidisciplinary board discussion with the involvement of the surgical oncologist, medical oncologist, radiation oncologist, nuclear medicine expert, and the radiologist, all sitting together, discussing the stage and the options of treatment, and then going ahead with whatever best is going to suit your patient.
Si vous avez un centre de cancer, il est recommandé d'avoir plusieurs spécialistes dans l'équipe qui discutent pour chaque cas pour décider de la meilleure option à utiliser.
Is there any role of upfront surgery like an esophagectomy? Yes, of course. In T2N0 diseases, especially if the disease is mid-esophagus, lower esophagus, or even GE junction and resectable on imaging, then we can consider, provided our preoperative staging is accurate.
Dans un cas avancé, nous pouvons suggérer des traitements beaucoup plus avancés.
In other cases, we should offer preoperative therapy, where there is a constant ongoing debate of whether to offer chemoradiation or chemotherapy and which is the best, which we will be discussing in the subsequent slides.
Dans certains cas, il est suggéré de procéder à une consultation pré-opération avant de savoir si c'est la meilleure décision à prendre ou pas. Et nous allons découvrir tout ça dans les prochaines présentations.
There have been several trials in this field. I would like to quote only the most important of this. And as we can see in the table, that is CROSS for squamous cell carcinoma of esophagus. CROSS was a trial which compared squamous cell carcinoma versus adenocarcinoma diseases, but their main challenge over here was to compare the role of surgery versus the role of neoadjuvant chemoradiotherapy followed by surgery. And they saw that patients who underwent neoadjuvant chemoradiotherapy did far better than patients who underwent for surgery first, irrespective of the adjuvant treatment. And even among this, the squamous cell carcinoma subgroup did far better than the adenocarcinoma.
Il y a plusieurs tests qui ont comparé les effets des différents traitements et nous avons vu que ceux qui ont opté pour des traitements avant d'aller vers la chirurgie ont obtenu des résultats meilleurs que ceux qui sont allés directement en chirurgie.
For the adenocarcinoma, the OEO2, MAGIC, ACCORD, and FLOT, which is not mentioned over here, these were the important trials which showed that the perioperative chemotherapy or neoadjuvant chemotherapy patients did better than upfront surgery patients.
Donc, pour l'adénocarcinoma, nous avons remarqué, comme nous venons de le signaler, que ceux qui ont opté pour d'autres traitements avant d'aller vers la chirurgie ont eu de meilleurs résultats que ceux qui sont allés directement en chirurgie.
The world had arrived at a consensus after the CROSS trial was published. And the CROSS trial established that the chemoradiotherapy group, followed by surgery, did far better than the surgery alone group, as you can see in the survival diagrams on the left side of the screen, and also seen in the forest plot on the right side of the screen.
Donc, après tous ces essais, il y a un consensus qui dit que les patients qui ont suivi un traitement de chimiothérapie suivi de la chirurgie ont eu de meilleurs résultats que ceux qui allaient directement en chirurgie.
So at this stage, it was decided that what was best for a squamous cell carcinoma locally advanced was to give a neoadjuvant chemoradiation, and what was best for adenocarcinoma of esophagus was to give perioperative chemotherapy.
Donc, après cela, il a été décidé que la chimiothérapie et la thérapie préventive avant la chirurgie sont suggérées pour les deux cas.
The biggest challenge was here to accept the fact that there was no head-on comparison between neoadjuvant chemotherapy and neoadjuvant chemoradiation, as each of the trials which I mentioned before had one arm of only surgery and the other arm with either of the two treatment groups.
Donc, le problème qui se présente ici, c'est d'arriver à un consensus qui dit qu'il ne faut pas forcément comparer les deux études, puisque l'une des études s'est basée sur un aspect et l'autre s'est basée seulement sur l'autre.
To answer this question came three trials: NeoAegis, ESOPEC, and JCOG Next.
Donc, trois essais ont été faits pour répondre à cette question. On a les trois noms qui sont listés sur l'image.
NeoAegis was a trial which compared the role of cross versus flot, that is neoadjuvant chemoradiation versus neoadjuvant chemotherapy with perioperative chemotherapy protocol in adenocarcinoma of esophagus. But what it showed was that the two treatment groups did not significantly affect the overall survival or the disease-free survival.
Le test Neo-Aegis a mis en valeur le fait que les deux groupes ne présentent pas forcément les mêmes résultats.
Then came the ESOPEC trial. ESOPEC was also run in esophageal adenocarcinoma, and it had compared flawed protocol versus cross protocol.
Ensuite, le test ISOPEC qui a permis d'avoir des résultats encore différents.
In this group, the main parameter which was studied was the median overall survival and the 3-year, 5-year overall survival. And as we can see in the graphical representation over here, there was significant difference in the overall survival between the two curves. The flawed group of perioperative chemotherapy did much better in the 55-month median follow-up period compared to the cross group. And the median overall survival of flawed was 66 months, which was far better than cross of 37 months.
Dans cette étude, il y a eu la comparaison du taux de survie des patients qui ont eu une consultation préopérative avant la chirurgie et de ceux qui sont allés directement à la chirurgie. Et on voit que le taux de survie est de 66% pour ceux qui ont fait une consultation préopérative et de 37% pour ceux qui sont allés directement en chirurgie.
This helped in concluding worldwide that if it's an esophageal adenocarcinoma, the flawed therapy is the best.
Ceci permet d'avoir un consensus que la méthode du float thérapie est la meilleure.
If it is an esophageal squamous cell carcinoma, what would be the best protocol? This question was answered by JCOG Next, and this is the trial I'm talking about. For all stage 1B, 2, and 3 disease, excluding T4, which were included in the trial, patients were randomized into 3 groups. They either received chemotherapy with dual regimen or 3 chemotherapy DCF regimen, or they were subjected to neoadjuvant chemoradiation.
Donc, il y a eu un test avec des patients qui sont divisés en 3 catégories qui sont un peu listées sur ce graphique.
And subsequently, patient underwent esophagectomy with D2 lymphadenectomy, and their overall survival was studied.
Donc, le taux de suivi a été étudié pour chaque groupe.
What was concluded was that the DCF, that is triple perioperative chemotherapy regimen, improve the overall survival over the dual regimen for locally advanced esophageal squamous cell carcinoma, and this subgroup actually did better than even the chemoradiation arm.
Donc, la conclusion était que la méthode DCF, qui inclut euh, trois méthodes, a eu beaucoup plus de résultats que les autres méthodes.
So the current answer is, if you have a fit patient who can tolerate the toxicity, a DCF should be the standard of care for neoadjuvant therapy in esophageal squamous cell carcinoma. But for other patients, a chemoradiation regimen can be used.
Donc, la conclusion est que si vous avez des patients qui sont bien portants, qui peuvent tolérer la toxicité, la méthode DCF est la plus suggérée, mais pour d'autres patients, il faut recourir à d'autres méthodes.
Now, there was a question of whether we should operate on these patients. So there is the question of bimodality versus trimodality treatment. Esophagectomy is not an easy surgery, and it's not without post-operative complications. If we could avoid esophagectomy altogether, will it be better for the patient? That can be achieved if the survival advantage of definitive chemoradiation is the same as trimodality therapy, including surgery.
Donc, les chances de survie du patient sont un facteur important à prendre en considération pour décider de quelle méthode choisir et laquelle aura des incidences similaires à une chimiothérapie sur le patient.
This is one of the important studies where definitive chemoradiotherapy was compared with neoadjuvant chemoradiotherapy followed by surgery for stage 2, stage 3 esophageal squamous cell carcinoma. But the study showed that the trimodality therapy had definitely better survival when compared to definitive chemoradiation.
Donc, cette étude montre que la stratégie de passer par la chimiothérapie avant une opération a montré beaucoup plus de résultats que celle qui consiste à aller directement à la chirurgie.
But still, in patients who are unfit to undergo surgery because of their comorbidity, age, or other factors, a definitive chemoradiation can be offered in cases of esophageal squamous cell carcinoma.
Mais pour les patients qui sont en incapacité d'aller en opération, la chimiothérapie peut être une option à suggérer.
What is the surgery that is done for esophageal cancer? Esophageal cancer surgery is an esophagectomy which involves removal of the entire length of esophagus starting from the thoracic inlet up to the gastroesophageal junction and designing a gastric conduit which is brought in the posterior mediastinal route to replace or reconstruct a neoesophagus.
Donc, ici, on explique la chirurgie qui consiste à l'ablation d'une partie de l'œsophage.
This approach to surgery can be either an open surgery or a minimally invasive surgery. In today's situation, for most of the cases, we prefer to do a minimally invasive surgery with either a laparoscopic approach or a robotic approach.
Cette opération peut être une chirurgie ouverte ou une chirurgie localisée, mais avec les moyens d'aujourd'hui, nous préférons aller vers une chirurgie localisée.
Robotic approach, we see that has significant better outcome in terms of the circumferential tumor dissection, in terms of the oncology of the specimen that is received, oncological dissection, radicality of surgery, and also in terms of early post-operative recovery of the patient.
La méthode utilisant la robotique a montré des résultats plus probants en ce qui concerne la localisation, le ciblage de la tumeur et aussi en ce qui concerne l'étape d'après et le traitement, après le traitement, l'état de santé, l'avancement du patient.
In some patients who are very frail and borderline fitness, especially if the tumor is in the gastroesophageal junction, not very bulky, we offer transhiatal esophagectomy, which is better tolerated than a transthoracic esophagectomy in such patients.
Pour des patients qui sont un peu frêles, qui ne sont pas assez robuste pour passer à ce type de traitement, nous suggérons de ne pas l'initier.
What is the adjuvant therapy that can be offered? Ideally, in a patient who has no residual disease post-treatment with a perioperative chemotherapy, radiation, or perioperative chemotherapy alone or neoadjuvant chemotherapy radiation regimen, mostly no treatment is needed. But in patients who have residual disease, this keynote trial, which showed the significance of adjuvant nivolumab, has proven that in a patient post chemoradiation, if there's a residual disease, especially in an esophageal squamous cell carcinoma, nivolumab can be offered and should be offered to decrease the chance of disease recurrence.
Pour les patients qui n'ont pas de résidus de traitement de la chimiothérapie, nous ne recommandons pas ceci, mais pour ceux qui ont des résidus de leur ancien traitement de chimiothérapie, nous pouvons recourir à cette méthode.
Though this effect was more seen with the case of squamous cell carcinoma, it is also applicable for adenocarcinoma.
Même si ces effets ont été plus vus pour le carcinoma, c'est aussi recommandé pour l'adénocarcinoma.
Once we have treated these patients, what is the surveillance strategy? Surveillance strategy depends upon what was the initial stage of presentation and what was the management offered. If it was T1N0 disease, then they are usually followed up with endoscopic surveillance, which is 3 monthly in the first year, 6 monthly in the second year, and annual thereafter. Imaging may not be recommended for a T1A disease and may be recommended for a T1B disease.
Pour les patients l'étape T1 et T0, nous recommandons une endoscopie qui sera de 3 mois pour la première année, 6 mois pour la deuxième année et une fois l'année ensuite.
If it is a locally advanced disease, then following the bimodality or trimodality treatment, it is followed with an imaging, which is usually a contrast-enhanced CT scan, thorax, abdomen, pelvis, or a PET scan, which is done 6 monthly in the first 0 to 2 years and annually thereafter for the first 5 years.
Si c'est une tumeur locale, nous recommandons un scanner qui doit se faire dans les 6 mois sur les 2 premières années et ensuite une fois l'année.
During surveillance following bimodality treatment, that is definitive chemoradiation, patient should also undergo endoscopic surveillance. If there's any evidence of disease recurrence, then a salvage surgery should be offered to those who can tolerate one.
Donc, une surveillance accrue doit être offerte aux patients juste après et s'il y a des signes qui nécessitent une autre intervention, celle-ci doit être faite.
So, what are the questions which are currently unanswered? Is there any role of neoadjuvant immunotherapy in management of CA esophagus? I think this is a very potential question which will find answer in the near future because immunotherapy has found its way significantly in lung cancer management, has proven its role in adjuvant management of esophageal cancer. So there might be a significant difference to the outcome and survival improvement if we include neoadjuvant immunotherapy in the preoperative management. Organ preservation is still debated. The problem with organ preservation is that even when we can offer definitive chemoradiation or early treatment with neoadjuvant protocol, there is no clear-cut way of proving whether there is a pathological complete response or residual disease, even with a PET scan and endoscopic surveillance. But probably in the years ahead, a more strict surveillance and screening protocol post-neoadjuvant therapy may enable us to preserve more organs and to get away without doing an esophagectomy and face the consequences of the lifetime changes subsequent to esophagectomy. But these are questions that we are eagerly waiting to solve in the near future.
Alors, pour l'étape à suivre, l'immunothérapie, au vu des résultats probants, a un futur radieux devant lui. Mais en ce qui concerne la préservation des organes, la question n'est pas encore tranchée au vu du fait que c'est pas, on ne peut pas déceler à coup sûr si les organes sont bons à être transmis même après le scanner et après plusieurs vérifications. Donc, les années à venir nous aideront à savoir si nous aurons des avancées sur ce sujet aussi ou pas.
Thank you. I would like to conclude my presentation over here. Over to anybody who wants to discuss anything further.
Thank you, Dr. Preeti, for the wonderful presentation. We do have some questions in the chat box. Dr. Christian has asked, how do you differentiate gastroesophageal junction cancer and lower esophageal cancer and the difference in their care?
Hi, Dr. Christian. So the protocol that we follow is by an endoscopic mapping. Our the medical gastroenterologists are usually able to tell us where exactly the tumor is located with respect to the GE junction. And a standard 40 centimeters, the landmark that we expect, which is slightly variable depending upon the length of the esophagus in the patient. Once that is determined, the mapping of the malignancy is done with respect to the gastroesophageal junction. And of course, we also correlate in the axial imaging the gastroesophageal junction and the endoscopic picture. And if there is any incongruency between this, we prefer to go ahead with the axial imaging representation and finally decide on the diagnosis accordingly.
Dr. Mukia has asked, what is the role of immunotherapy in esophageal cancer?
Hi, Dr. Mukia. The role of immunotherapy in esophageal cancer is currently established in the adjuvant setting, more so ever for esophageal squamous cell carcinoma. But any patient who has undergone a neoadjuvant therapy protocol completion for an esophageal cancer and undergoes a surgery and there is a residual disease, then we prefer to follow these patients with adjuvant nivolumab in these settings. But if there's no residual disease, then we do not advocate adjuvant nivolumab for these patients. And as I had previously discussed, the role in the neoadjuvant setting is still experimental and yet to be answered.
Yaovi, can you translate that? Dr. Mukia is from DRC.
Oh, sorry, I didn't follow. Can you do just a summary so I can translate?
No problem. I can do it again. So what I was saying is that the role of immunotherapy in esophageal cancer is established in the adjuvant setting. If there's a residual disease post-esophagectomy in a patient treated with neoadjuvant therapy, we do advocate adjuvant nivolumab. But in the neoadjuvant setting, it is experimental.
Donc, le rôle de, de l'opération gastro-ésophageale est beaucoup plus dans le domaine dans le traitement avancé. Et s'il y a des résidus de traitement dans la chimiothérapie précédente, oui, on peut y avoir recours.
Dr. Elisha has asked, cryotherapy is one of the treatments options for the cancer. Would you repeat the disadvantages of applying cryotherapy for the esophageal cancer?
Hi, Dr. Elisha. Cryotherapy, along with the other ablative therapies, can be applicable only in very early and especially screen-detected cases of esophageal malignancy. The problem is, when we are dealing with these malignancies, we have to be extremely accurate with the staging. If the endoscopy and an EUS is able to detect a flat, high-grade dysplastic or an early intramucosal carcinoma, in these cases, we can apply, but it will result in structural abnormalities at that site, making it difficult for us to follow up on surveillance. Hence, if the disease has any suspicion of nodular disease or further intramucosal carcinoma invading into the submucosa, into the muscularis propria, we recommend going ahead with an endoscopic resection rather than any ablative procedure like cryotherapy alone.
Dr. Wasim has asked, given that the prevalence is much higher in men than in women, is there a predisposing genetic factor?
Hi, Dr. Wasim. This is a question on my mind as well. we do not have any established genetic risk factors for why it is more common in women, more common in men than in women, though a lot of it is attributed to probably the other risk factors like the habits like smoking and diet habits, which may be leading to this. But when we talk about genetic risk factors, I really don't have an answer here yet.
Done. Yaovi, could you please translate that? Dr. Wasim is a French.
Oui, nous n'avons pas de réponse claire en ce qui concerne le facteur génétique qui pourrait expliquer le fait que cela affecte plus les hommes que les femmes, mais nous pouvons l'expliquer au travers des habitudes, essentiellement la cigarette et d'autres habitudes qui peuvent justifier le fait que ce soit plus prévalent chez les hommes que chez les femmes.
Uh, Dr. Wasim has also asked, in cases of widespread metastasis, can chemotherapy improve the prognosis?
Yes, Dr. Vasan. In widespread metastasis, there is a possible benefit that can be offered by chemotherapy along with immunotherapy or targeted therapy. Now, how much of survival advantage it can cause in terms statistically, maybe a couple of months, but it will definitely have an improvement in the quality of life of the patient in this mean duration.
Oui, la chimiothérapie peut avoir un avantage dans le cas de la métastase généralisée associée à l'immunothérapie, mais combien de temps ça peut donner? Peut-être quelques mois, mais ça aide aussi à améliorer la qualité de vie après le traitement.
Dr. Shipamba has asked, role of imaging in the workup of esophageal cancer.
Hi, Dr. Shibaba. The role of imaging, as I have discussed previously, is essentially any axial imaging, whole body imaging, which could be a PET-CT if it's available. If it's not available, a contrast enhanced imaging covering the neck, thorax, abdomen, and pelvis will be required for essentially staging the disease. In addition, an endoscopic ultrasound is used in early stages for more accurate TNN staging, and bronchoscopy and laparoscopy may be used in locally advanced diseases or laparoscopy to rule out peritoneal metastasis in case of adenocarcinoma.
Dr. Morris has asked, what are the methods of preventing esophageal cancer?
Yes, Dr. Morris. So prevention of esophageal carcinoma essentially starts with understanding what are the risk factors. So one of the most important risk factor, which depends upon the histological subtype, is for an adenocarcinoma. It could be because of obesity. It could be because of a lot of reflux disease that patients have. It could be added on by smoking and alcohol. So limiting smoking and alcohol is essential. And if there's a gastroesophageal reflux disease, that needs to be managed medically and the problem corrected. And in patients who have an already existing condition, an endoscopic surveillance, which is started early with more stringent monitoring, will make a difference. For esophageal squamous cell carcinoma, the pathology may be related to having, may be related to smoking, may be related to diet habits, and regulation on that can make a difference.
Yaovi, can you please translate?
Oui, les facteurs qu'il faut suivre pour une prévention sont essentiellement l'obésité, les maladies préexistantes ou les habitudes d'alcool ou de cigarettes. Tous ces facteurs peuvent aider à réduire le risque.
Dr. Preeti, I guess these are the questions. That's it. If there are any more questions, I'll club them and send them over to you through text. Okay, Dr. Dinaul has asked, upon your experience, what do you recommend the junior doctors about such annoying disease of our patients?
Hi, Dr. Dinal. I see that there's a lot of ignorance in our community, especially in our country, when it comes to understanding a complex disease like esophageal cancer. Patients have early subtle symptoms of difficulty in swallowing, but it is often ignored and considered as a representation of some other common ailment. So the need for awareness is foremost. Patients need to be explained about the need to go for an early medical evaluation, because an early endoscopy and early disease detection can make a big difference in terms of outcome. And as far as the further management is concerned, as doctors, we should be at we should involve ourselves in educating more and more public about the disease, about the diagnosis, and about all nutshell treatments that we have in hand, so that we can spread this message across to most people that if detected early, we can offer maximum curative options to them.
There is one more question from Dr. Wasim. He's asking, in routine practice, we frequently encounter cases of PPD poisoning due to suicide attempts, which lead to caustic esophageal injury, resulting in chronic esophagitis. In such cases, can chronic esophagitis be considered a precancerous lesion?
Yes, Dr. Vasan, that is a very valid question. Even in our community, we face a lot of cases of caustic esophageal injury, and these chronic esophagitis can eventually lead to stricturous disease and can become a predisposing cause for esophageal cancer. And such patients who have undergone a caustic injury, and if they survive such an injury and develop a stricturous disease, they should be on very stringent surveillance protocol.
Yaovi, please translate for the doctor.
Sorry, a quick summary, please.
Yes, the answer is, Yovi, is that caustic injury is a significant predisposing condition which can eventually lead to precancerous transformation and malignancy, and hence such patients should be on more strict surveillance.
Donc, sorry, I think I didn't got, you say caustic injury, right?
Caustic injury, yes.
Okay.
Poisoning associated caustic esophageal injury can become a predisposing factor for esophageal cancer.
Ok, l'empoisonnement alimentaire ou oui, l'empoisonnement alimentaire peut être un facteur prédisposant pour ce type de maladie, oui, qui peut amener au cancer.
Dr. Guttu has asked, is there any specific age at which to start screening by endoscopy or another modality?
Hi, Dr. Guttu. In our country, our practice is to recommend screening after the age of 35 to 40 years. This is a variable number in terms of institutional protocol and guidelines which are followed by the respective hospitals and the specialty centers. In our country, we do expect that patients who have GERD symptoms or have a risk of Barrett's esophagus should start screening at the age of 35 to 40 years.
Dr. Wasim has also asked, but in this case, what preventive measures should be taken? I think he's talking about PPT poisoning.
Yeah. Hi, Dr. Vasan. So the preventive measures that we can take in these patients is if the patient has extensive stricturous disease, which practically what we see is most of these patients develop stricturous disease, which leads to significant dysphagia and chronic inability for oral nutrition. In such patients, an offer of esophagectomy and neoesophagus is offered to them. But in patients who do not develop such stricturous disease, a 6-monthly endoscopic evaluation with an endoscopic biopsy of any suspicious lesion is to be done. Further imaging is not required unless it's a biopsy-proven condition.
Donc, les mesures préventives peuvent être un suivi accru dans une période de 6 mois pour éviter que de tels empoisonnements puissent amener au cancer.
To answer the question of Dr. Guttu, so we take up the patients for endoscopic mapping. And in endoscopic mapping, all the areas which show dysplastic changes are biopsied. And after multiple biopsies, they are kept on surveillance if they don't have any evidence of dysplasia. If the patient has low-grade dysplasia, then the patient is kept on follow-up. If the patient has evidence of high-grade dysplasia with a flat lesion less than 2 centimeter, we ablate them. And if the patient has high-grade dysplasia, which is more than 2 centimeters, or which has nodular appearance, then we prefer to advocate endoscopic resection and follow-up of histopathology on the EMR specimen.
Dr. Preeti, I guess all the questions are done. If there are further questions, I'll club them and send them over to you. I think we have taken enough of your time on a weekend. So thank you for the wonderful presentation. Thank you for your insights. And Yaovi, thank you for the translation. Before we conclude, I have an announcement to make for our doctors. So we are going to organize an online OPD with Dr. Preeti tentatively on Thursday. So you can look for 2 to 3 patients who are diagnosed with cancer, and you can bring them to your clinic on Thursday. Dr. Preeti will be available for consultations on a Zoom meet. It will be a video consultation. So it will be really helpful for your patients and for your medical tourism practice as well. Yavi, you can translate that.
Donc, le jeudi prochain, nous aurons une réunion à laquelle vous pouvez assister en venant avec vos patients qui ont les maladies dont nous avons parlé. Donc, ça peut être une occasion pour eux d'avoir un diagnostic encore plus poussé et aussi une occasion pour vous de booster encore plus votre tourisme médical.
So I think we
A
can.
very thank you. A very big thank you to the team which has organized this. And I also appreciate and thank all the participants and doctors from so many countries who have actively involved, and would like to look forward to more interactions with you in the future.
Thank you, Dr. Preeti. Thank you, everyone. Thank you, Yaovi.
Thanks, everyone. Merci à
Thank
tout le
you,
monde.
Yavi. Thank you, all doctors.